So this is how the outline is going to be. We're just going to discuss two cases, a diagnosis, a bit about the numbers and the treatment strategies. So there's a 45-year-old lady who fell in the bathroom on an outstretched arm and there's a distal radius fracture. It's about a year ago. She comes to Tejal's clinic and she has stiffness and pain. There's another patient who's come after a plaster. The plaster has been removed, but she has disproportionate pain. There is swelling. And she has come to the clinic and the surgeon says that she's not responding to medical management. So now, how do we manage both these cases? This is just a representative X-ray. I'm sure I've learned quite a few things here today. So this is a patient I was talking about, the one with pain. If you notice the middle image, for you, all of you, I'm sure the images on either side may not be relevant because you know very well how to address it. But a subtle clue here is that she's covered her hand with her dupatta because touching that hand itself is painful. The least amount of touch there provokes disproportionate pain. So these were some of the signs that suggested a neuropathic process in action. This is another lady, again a representative picture of how bad things can be because she had bilateral CRPS. Now, we know that pain is both a sensation and an emotion, because it has two elements to it. The peripheral component that reaches still short of the thalamus, and everything above that is perceived as a higher signal. In fact, there are studies with even knee arthritis, which shows changes in the motor cortex, in the sensory cortex with functional MRI scans. So as we understand pain, we know that it's not isolated in that we cannot just say it's a peripheral nociceptor, but it can go all the way to the cerebral hemispheres. So it's the sensation and emotion. Now, my quick question to the seniors here, to the colleagues here, and to everyone who deals with people who have wrist injuries: how do you determine this patient is going towards CRPS? What is that thing that says this looks not normal? Most patients heal well, because I'm sure after fractures, most patients heal well. And I'm sure that lady who had that hardware accident also would have done, she might have healed also. We don't know. She might be getting back with her deformity. But there is a percentage, as sir rightly said, that there's a percentage of people who don't heal and they come to us. And what are your triggers? What do you think of when you feel that this person might be going into CRPS?
All of these put together.
Shoulder arms.
Shoulder arms.
That if a person is having it, that means one or two.
Yes, shoulder arm.
MP joint. The MP joint is a culprit. I think Parag showed that first X-ray, that if you get an MP joint which is in full flexion, that the plaster should never cross it should come out right up to the distal crease, but never cross it. That is the principal cause. If you have full flexion and you give a cast, they have a good outcome. I have never seen patients with a CRPS. MP joint is the culprit.
Shiny skin, someone mentioned. Emotionally labile, someone mentioned. So so simple trick that again for the residents is, if you ask the pain descriptor, so if some person describes the pain as a sharp pain, then you know that they are describing it in terms of cutaneous and peripheral sensation. The moment someone says horrible pain, horrible is not a peripheral sensation. Horrible is an affective word. So horrible, terrible. The idea that you can get about different types of pain from a history are very subtle. So you know how much of the cortex is involved, emotional lability. So even despite all methods available to us and investigations, we still rely on clinical diagnostic criteria for CRPS. There is no gold standard investigation. This is one of the articles we had published in 2013, because we used to do ultrasound of the flexor compartment, and we'd seen that there's a change in the consistency of flexor muscles pre and post treatment. So the ones who were improving, there was an improvement, but we could not make sense of it. And I saw one of the presentations where MSK sonography was being done. So there's so much in the last 15 years that has changed. It's making it more and more easy to pick it up early and give us an idea of what must be happening mechanically. So if someone has to do some research on it, we have to use the Budapest research criteria. there has to be one symptom in all 4 domains, one sign in 2 or more of the following domains, and most importantly, no other diagnosis explains the signs and symptoms. As Rohan just mentioned some time back that, the diagnosis is the tricky part. I'm not an orthopedic surgeon. She knows more orthopedics than me as an orthopedic physical therapist. But as a pain specialist, when someone comes, I run it by the surgeons and ask them, is there anything structural? And then relying on your feedback, if I've ruled that out, then I can proceed on it as a neuropathic process. So we come back to the risk factors. We know that motor nerve injury, any nerve injury, higher risk. You have female gender, known to have a higher propensity for multiple, maybe humoral factors we do not know. This is one of the recent studies. They did a multivariate analysis and they said that complex fractures, osteoporotic patients, higher pain scores, preoperative anxiety, all of that is associated with a delayed treatment course. And all of us know that intuitively, especially all the senior surgeons know that this patient might take a little longer than otherwise. The other importance of this is that 30% of them are not capable of working. And this is where the next part of our treatment comes in. And I'd like to take this route to call Dr. Tejal in and, So usually it relies on physical therapy and functional restoration. So just going to ask her to speak about that.
Thank you. Thank you, the organizing committee, Dr. Warrier, sir, for giving me this opportunity. Now, what challenging situations do you encounter with wrist fractures? What does the patient mainly complain of? The one on the left is what I come across, which I can manage to a certain extent. But on the right is what I can't. It's not under my control. And I think even the surgeon does not have any hold on to that. So most of the cases are pretty straightforward. Get better. We do the range of motion exercises, strengthening. But what about the challenging cases? So I feel a multidisciplinary approach is what helps patient gain their strength, the range of motion, helps them get back into their ADL activities. And these are some of the things that we incorporate in our practices. Now I'll talk about some of the intervention strategies that we normally use at our clinic. This is just a summary. The last two I've kept them separate because I don't use it much. But although there are studies that show that GMI and mirror therapy also work, I use the upper half. Now, a lot of patients come with a lot of sensitivity. Some even say that they can't tolerate the touch of the dress also on their skin or the shirt on their skin. So what we try doing is we start with sensory discrimination. Here we use different textures and we have the patient stroke their skin in one direction. It should either be distal to proximal or proximal to distal. To start with 30 seconds and then gradually work their way up to 3 minutes, at least twice in a day. So 4 to 5 different textures. It can be silk, cotton, paper, brush, something like that. Here we've used a spiky ball. Another thing that I like to use is a contrast bath, which works very well, although it is very tedious, but I sort of convince my patients to use it. I have them dip their hand in a bucket of warm water. Even if they're swelling, they still do it for a few minutes. And I suggest that the bucket should be as deep as possible. So it's not just the hand, but we are covering the whole forearm. I want all the muscles to be, taken care of because as we know, the fascia of the forearm goes all the way up to, the biceps also. So everything is connected. And I have them do the contrast bath with warm water and then with water with ice cubes. So the ice also helps to decrease inflammation. And simple exercises in water. It can be just writing alphabets. It can be just making a fist and opening up, counting, and getting their intrinsics in action. So just spreading the fingers. The other thing we come across is a lot of edema. So here I like using Coban wraps, which are elastic bandages, 1 inch in thickness. And we cover the finger from distal to proximal. Same with the palm, keeping the fingertips free so that we can check on for the circulation. And this gives fantastic results in controlling the edema. Now, we've taken care of the pain to a certain extent, we've taken care of the sensitivity, but without movement, the patient still has a stiff hand. So we use this a lot in our practice. We do tons of manual therapy. Yeah. So there are different techniques in manual therapy. I follow different schools of therapies. To name a few, Mulligan, Carlton Bone, Ceriax. Here I'm using something called as movement with mobilization, where I'm actually taking care of the mid-carpal joints to improve the range. These are the basic exercises. At times we start with the tendon gliding exercises so that we can take care of the stiffness and the range from the very beginning. At times when the stiffness is too stubborn, we've even used plastering in certain patients using a simple 10 centimeter Gypsona plaster. And strengthening starts from day one. So from the day you start contrast therapy, strengthening starts. The alphabet itself activates all the forearm muscles. We use tools like Therapati, which give graded resistance, even Therabands and dumbbells. Therapati works very well with most of the hand cases. Now, as we are all modernizing, so the techniques are modernizing, we've started using VR at the clinic. Mahesh and I, both of us, we are using this. This is an immersive therapy. Now here you can see the girl, she's wearing an Oculus and she's trying to do her range of motion. I'll show a small video where this is what we can also see so that we can control it. And the patient also is seeing the same thing on the screen. So if you see, the right hand has a better range of motion and the left doesn't. And as they are in this virtual environment, they don't feel pain as much. Their more focus is in trying to get the game, winning the game probably. And so here we're using the patient, we've asked them to, it's a magical potion and they have to get as many points as possible. And here we've seen that the patients actually gain more motion immediately. And the patient can also see there's a pre-evaluation and a post-evaluation after treatment. So you can actually see the first image that was there where the hand was moving, then the patient can see how much they've covered. So this was one of the cases which did not do well. This was at 6 months. In spite of everything that I tried, the pain did not reduce. So that's where then Sir and Mahesh come back into picture. And this was one case which had a lower end Achilles fracture, had a lot of stiffness and pain, and now she's back to playing tennis. She's gained full range of motion. Her hand looks absolutely normal. And so for me, functional restoration techniques are the cornerstone of physical therapy. So to summarize, these are all the techniques that I normally advise and we practice at the clinic. So where pain was a barrier and the hand function was affected, I'll hand over the next session to Mahesh so that he can take over. Thank you.
Yeah, thanks, Tejal. So I did the immersive therapy myself because I wanted to know how it works. And the beauty of it was I got a call. I played it for about 15 minutes. I did it for a little extra time. And then I got a call and then I had to reply on WhatsApp. And I took the phone and I'm typing the message and my hands were feeling different. And my son had played this before. So he's telling me, "Haath alag lag raha hai na?" I said, "Yes." He says, "Wash your hands." So I washed my hands and it didn't feel that way. So there's something happening at the cortical level. The reason we are using VR is for a lot of post-stroke and central patients, but it's helping with some of our CRPS patients because of the central component. This lady, the second lady in whom it didn't work well, because whenever she would go for physiotherapy, she would not allow Tejal to do the therapy, and she would hold back and not, and cry or shout, and then they would skip sessions. So we had to do something for them. So medications, and as orthopedic surgeons, what medications would you prefer to use when your patients come with these exquisite pains? What would you prefer? Yes, sir. Yes, sir. Standard NSAIDs. Bisphosphonates, vitamin C. Yes, sir. Local head. Yeah, the distal sodium channel block. Yeah. So any swelling reduction, because I find that there is a wet phase when there's a lot of water there, and when the water goes away, it's just stiff. So the hand becomes very stiff after that. So a lot of the distal sodium channel block. So a lot of things can help in pain reduction. So I also do palliative care. So we say that love is the medicine, and increase the dose of love. But in gabapentinoids, we can't increase because they feel very drowsy. So we have to. These are many of the things that we have tried. I've tried ketamine for one patient with complex regional pain syndrome, but many things can be tried. We've tried botulinum toxin also, where the contracture element was higher. IV local anesthetics, lignocaine can be given. Bisphosphonates help, oral steroids help. So some of these things have made a difference. Despite this, if it doesn't work, we sometimes rely, if you have your colleague in anesthesia who's comfortable giving ultrasound guided stellate blocks. So that's the carotid, and that's the longest colli here. That's the longest here. And you can see the needle coming in, and this is the location of the stellate ganglion. I didn't have my own video, so a colleague was kind enough to lend it to me. So we do this with ultrasound guidance. This structure, interestingly, is the IVC, IJV, which is collapsed because of the pressure of the transducer. It's technical. So we inject behind the carotid, and we get good results with sympathetic blocks. The swelling reduces. In some people, it is more recalcitrant, so we have to put in an intraclavicular brachial plexus catheter, in the same way that you would keep it tunneled and keep it for a complex post-operative pain patient. We keep it tunneled, and then the mobilization can take place more aggressively. And with that, at least you prevent it from going into stiffness. The duration of catheters, I would prefer for a short term for about a week or so, but there have been instances where I used to practice with a senior pain practitioner, and the other madam would keep it for about a few weeks, 4-6 weeks or so. So we've always seen that these work. I still am not too happy with conditions where the joints are stiff, because no amount of movement seems to help them. That's where probably surgery might come in. This is the catheter being placed there. So coming back to this patient, the lady who came to us, and she had allodynia, she was not allowing us to touch her hand. This is the result. This was the result for the lady with severe stiffness. She was not able to move, and we managed to get a decent range of movement for her. We've tried a spinal cord stimulator insertion for a person with a brachial plexus injury, unrelated, but these are images from that. So the take-home message that we have at the end of this is that, from the pain point of view, CRPS 1 or 2, where there is nerve injury, they are perplexing. We will encounter this at some point of time. There's no single gold standard diagnostic test. Even today, it's clinical. And there is no single drug or therapy that will work as a standalone. I think it's complex, because if you have to address the emotional factors, the physical rehabilitation factors, and multimodal treatment should focus on early diagnosis. So if you can keep a threshold of suspicion for someone who comes with persistent pain, swelling, and guide them, and please, if you can encourage them to mobilize, as sir rightly said, that if the cast doesn't involve the MP joints, and that is the culprit, if there is not, the hand doesn't move, for some reason the body perceives this area as being super sensitive, and it goes into a sensitized mode. So moving it earlier helps, and consistent physical therapy helps, because sometimes patients also ask how many sessions to take, how many times should we come, or things like that. So they have to be aware that this is a process, and not a one-off thing. And soft tissue, today I learned so much about soft tissue involvement. That can be also a key. So thank you for this opportunity again. Tejal, any comments?